In this video, Dr. Ramaraj discussed the anatomy and diseases of the pericardium, including acute and recurrent pericarditis, pericardial effusion, cardiac tamponade, and constrictive pericarditis. He has highlighted the common symptoms, diagnostic criteria, and treatment options, emphasizing the importance of recognizing EKG changes and the clinical signs of cardiac tamponade. We have also covered the management strategies for both acute and chronic cases, including medications like colchicine and NSAIDs, and the need for urgent intervention in severe situations. Please review the treatment protocols and be prepared to discuss any questions or cases you may have in our next meeting. Thank you for your attention.
Yeah, so this is the picture I was talking about. There's the sternum and the heart, and then the pericardium sac right there. And then this is when it's inflamed. It's right here. So some symptoms of acute pericarditis. Fever is most common if it's infectious, and you could also have flu-like respiratory or GI symptoms if it's viral, shortness of breath, and then with the chest pain, it'll be a sudden onset on the interior chest. It's sharp and pleuritic, so it's also worse when the patient is laying supine, and it's improved when they're sitting up and leaning forward because it'll reduce that pressure on the pericardium. It's worsened by inspiration or coughing. And some signs of acute pericarditis. So you'll see EKG changes such as widespread ST elevation and PR depression. And then with your stethoscope, you might hear friction rub, which is a scratchy sound that's resulting from the friction between the two inflamed layers. And this shows the EKG changes in acute pericarditis. So stage 1, it's usually seen in the first few hours or days, and you see that widespread ST elevation and with the PR depressions. And then with stage 2, seen in the first week where it normalizes. And then stage 3, the last stage, it's usually self-limited, it goes back normal. And then
one other is to look at AVR, and you can see actually PR elevation in AVR, and sometimes that's a little bit more apparent than PR depressions everywhere else.
Okay. And then these are just EKG changes in acute pericarditis versus acute MI. It just compares the two, so I thought it'd be good to add it. In a STEMI, the ST elevations are limited to the grouping, so like in inferior leads, whereas in pericarditis, the ST changes are more generalized. And then having concurrent ST elevations and T-wave inversions doesn't really occur in pericarditis, but it can coexist in acute STEMI. Okay. And then how to diagnose it. So again, a chest x-ray will be normal unless there's also a pericardial effusion. And then you'll have lab works. You'll do CBC, troponins, ESR, and CRP, and you'll have elevated results for those. The echo, again, will be normal unless there's a effusion. And then less common testing, and it's more done in the hospital setting, is blood cultures if they have a fever or pneumonia, and then a TB skin test if they're immunocompromised or they have a history of HIV. And then for the diagnosis criteria, you need at least 2 of the 4. So either like typical chest pain that's improved with sitting up and leaning forward, pericardial friction rub, EKG changes, or new or worsening pericardial effusion seen on echo. For treatment, the first line is colchicine with an NSAID, either aspirin, ibuprofen, or indomethacin. Ibuprofen is preferred. And then second line is colchicine with prednisone, and that's usually if it's refractory or contraindicated to NSAIDs. And then third line is a combination of all 3. And then fourth, which is very rare, less common, is a pericardiectomy, and that's for a recurrent pericarditis. And this just has the doses, some side effects of colchicine to let the patient know about diarrhea, nausea, vomiting. Again, NSAIDs, ibuprofen, 600 to 800, 3 times a day, then taper. Aspirin, 650, 3 times a day, and it's preferred over NSAIDs if it's post-MI. Indomethacin is most common for recurrent pericarditis. And then prednisone as well is an alternative to NSAIDs and can be used in pregnant patients if they are over 20 weeks pregnant. And then also let the patient know to restrict strenuous physical activity until symptoms have resolved, and then no competitive sports for at least 3 months post-resolution if they do participate in that. When to admit to the hospital: if they have a fever, acute trauma, if they're on warfarin, or a week of medications, if their effusions are moderate to large, elevated troponins, immunosuppressed. Allow other reasons like TB, infections, things like that. And then again, with recurrent pericarditis is when a patient continues to have flare-ups weeks after the initial treatment. An EKG demonstrates nonspecific STT wave changes. Echo and X-ray are usually normal. Treatment is, like I said, the colchicine and the NSAID, and then or indomethacin. And then if they're still having persistent symptoms, you can add prednisone. Avoid strenuous activity, and then pericardiectomy, which is a surgical procedure, and it removes some or all of the pericardium, and that's after failure of medical regimen. Constrictive pericarditis is when the pericardium is thickened and it's inelastic. It restricts the cardiac filling. So symptoms for this will usually present months to years after the initial injury, and can occur after any pericardial disease. The symptoms include peripheral edema or just overall generalized edema due to fluid overload, and then diminished cardiac output will result in fatigue and shortness of breath, elevated GVP. You do an echo or cardiac MRI, and then a left heart cath can confirm this. It can resolve spontaneously with medical therapy within 2 to 6 months with the colchicine and NSAID. And then if it's refractory, add the prednisone, or you could do the surgical procedure. So a pericardial effusion is when there's excess fluid in the pericardial sac surrounding the heart. So right here, you can see that in this picture versus a healthy heart without effusion. Normally, it should be between 15 to 50 milliliters. Reasons is pretty similar to pericarditis, so having acute pericarditis in the past, cardiac tamponade, new cardiomegaly, trauma, post-surgery, post-MI, renal failure, and then with pericardial effusions, they can happen with severe hypothyroidism with mixed edema. The signs or symptoms of this is not really specific. Usually there's no signs or symptoms, and you'll most commonly come across this as like an incidental finding on an echo. So for the EKGs for pericardial effusions, most common you will see sinus tachycardia, low QRS voltage, and electrical alternans. Electrical alternans is when there's alternating amplitudes of the QRS, and that reflects the back and forth swinging motion of the heart and the fluid. So you can see that here on this EKG. Usually it's in V2, V3, and then V4. And then on the chest X-ray, you'll see cardiomegaly. At least 100 milliliters of fluid has to accumulate before the silhouette enlarges on the chest X-ray. Then treatment for this, so there has to be indications for removing the fluid. 2 of them are cardiac tamponade, so some symptoms of that: fatigue, shortness of breath, syncope, and infectious pericarditis, where a patient has fever, tachycardia, or TB/fungal infections. And then how to remove it. So they'll do a percutaneous pericardiocentesis, which basically the needle and cath drains the fluid from the heart. And then they'll leave a cath drain in for up to 5 days to slowly remove the fluid. And then they can also, an alternative to that would be a surgical drainage, such as a pericardial window. That's most common for recurrent cases, where they remove all parts of the sac to drain excess fluid. Cardiac tamponade, that's caused by the pericardial fluid accumulating under pressure, and it impairs cardiac filling and reduces stroke volume. The cardiac chambers become compressed because of the increased pericardial pressure that's exceeding the cardiac filling and diastolic pressures. So all the causes of pericardial effusion can lead to this. Most common is neoplastic, TB, infection. The most common cause is actually complications of invasive cardiac procedures and acute MI, aortic dissection. Some signs of this are sinus tachycardia, elevated JVP, peripheral edema, hypotension, pulsus paradoxus, which is when the systolic blood pressure decreases by over 10 points on inspiration, and this is most common in severe tamponade. And then Beck's triad, which is low arterial blood pressure, dilated neck veins, and muffled heart sounds. And then fever if it's infectious. Symptoms, chest pain, shortness of breath, fatigue, syncope. In acute cardiac tamponade, it's most common in a rupture of the heart or aorta, aortic dissections, or perforations due to invasive procedures, drainage, as it can cause cardiogenic shock, especially if they're tachycardic, that requires prompt, urgent drainage. Subacute it pretty much happens over days to weeks. It's most common in neoplastic and idiopathic pericarditis. For this, the diagnosis on the EKG will show sinus tachycardia with low voltage. You'll also see that electrical alternance again. The chest x-ray will be nonspecific and may show some cardiomegaly. And then the echo can show pericardial effusion or cardiac chamber collapse. Cardiac cath is usually performed during the drainage procedure, confirmed by identifying hemodynamic findings prior to fluid removal and then after resolution of the hemodynamic abnormalities after drainage, so that before and after confirms the diagnosis. See right atrial pressures elevated, pressures equilibrating, and inspiratory increase in right-sided pressures and reduction in left-sided pressures. The treatment for this is urgent drainage via pericardiocentesis or surgery, and then continuous telemetry, echo prior to discharge, and then 1 to 2 weeks post-discharge. That's it. Any questions?
Tamponade is like a subset of pericardial effusion. It's usually an urgency or emergency because of the hemodynamic collapse. It's a clinical diagnosis, so the Beck's triad is what you look for. You also want to perform the pulsus paradox, which is, like you said, the measuring the blood pressure. Yes, there are echo findings on it, but if you're really suspecting it, they should go to the emergency room and be promptly treated with a pericardiocentesis. Like you said, I mean, it's something always to consider with the pericardial effusions and cardiac tamponade. Now that we're doing so many more cardiac interventions, left heart caths is one of the worst things that can happen, because if say we put a stent in and the coronary artery perforates, then that blood is now going to leak all into the pericardium, and it's not the amount of fluid that collects, it's about how fast it collects, because it's more about pressure. The pericardium is fibrous, it's not compliant, it can expand, so if something accumulates slowly, like say a malignant pericardial effusion, then it accumulates slowly, that pericardium can stretch and comply and won't have an increase in pressure as bad. But if it's something like a perforated coronary artery, it's going to accumulate very quickly. The pressure in the pericardium will accumulate very quickly. Then it's going to overcome the pressures in your heart. And so your lower pressure chambers are your right atrium, right ventricle, and those will actually start to collapse, and that'll be a hemodynamic collapse. So you can give them fluids to temporize them, but yeah, the treatment in those patients is urgent pericardiocentesis. But everything else was, I agree, it was a great presentation.
Yeah, good job. One comment on clinical signs. Patient acute cardiac tamponade, they live on 3 things: tachycardia, tachypnea, and preload. So usually in cardiac emergency situation, you give them heavy sedation, they die because they stop their breathing. Why? Tachypnea create negative thoracic pressure. They suck fluid into the right ventricle to maintain hemodynamic stability. You sedate them, they die. You give them heavy sedation, they slow down the heart rate, they die. If you give them diuretic, they die because you decrease the preload. And yeah, those are the 3 things must not done. So in emergency, we do it under local. Whatever ultrasound guided or the most people do it epigastric subxiphoid area, and usually they're very successful. They don't usually acute tamponade situation. They don't have lots of fluid. They don't. Versus chronic, that's even a blind chicken that pick up the fluid. The diagnosis from echo very simple. Yeah, you will see discordance of the LV volume. The LV increase in volume during expiration, in inspiration, right ventricle increase in volume. They bounce back and forth. It's called swinging hard. And you see right ventricular collapse during early diastole, right atrial inversion, plethora of IVC, backflow of hepatic vein. So those are very, and the clinical signs are they couldn't lay flat. You put them down, they scream bloody murder. Okay. So the very tachycardic, you see electrical alternance on the rhythm strip, and the pulse paradox, as you mentioned before, those are very typical signs of acute cardiac tamponade, very easily detected. And there's also always a reason. From an interventional cardiology standpoint, we did it. Yeah, dissection, permanent distance, all these things. Yeah, very common. Okay, but aortic dissection, they come in emergency room. Then the CT will pick up the aortic dissection, or regular echo, you may pick up the flap, dissection flap. Yeah. Yeah, those are the acute. The chronic is a different issue. Yeah, but anyway, yeah, that's my few sentences. Okay.
Thank you.
Yeah, that's a great one. Sona, it's a very nice talk. This is yeah, Dow and Dr. Lowe said, mostly clinical. Clinical is more than echo or anything, so which is very good. Any other questions from the group?
And it looks like heart failure. So, I mean, some of the pericardial effusions I've seen, they come in, pull the legs, severe dyspnea, severe orthopnea, they get diuresed, then they lose their pressure, and then they lose their preload, and then they collapse.
Yeah.
So you got to be careful about that. And then the other thing I wanted to mention was occluders, like Watchman, Lariat, those kinds of things, have instances of pericardial effusion. AF ablations can happen, and most heart procedures it can happen in. And then going to the pericarditis, I think you mentioned it briefly, but one thing to keep in our mind as interventional cardiologists is post-MI pericarditis or Dressler syndrome. It's pericarditis after an MI or after stent placement. They get the irritation. You treat it similarly, pericarditis. And then pericarditis can be a real big pain in the butt because you start taking people off the colchicine and the NSAIDs, and it'll come back. It's really, really, and sometimes people used to get put on steroids. Now there's new medications you can put patients on that are anti-inflammatories are bad news in pericarditis, so you don't want to do that.